Good afternoon, everybody. Thank you for coming this afternoon to the Superintendent's Insurance Advisory Committee meeting for June 24th, 2020. Let's do a roll call of who has called in and who is in attendance. Can we start with who is on the phone, please? Is anyone on the phone? Can they hear me? Okay, we'll start. Ms. Gaylor, will you start and just let's go around the room. Mr. Loretta is here. Mr. DeVoe is here. Mr. McAlpine is here. Leslie is here. Mr. Colucci is here. Lisa, what did I say, Leslie? Oh, sorry, Lisa. I had the L part right. It's been a long day. Leslie is here. I think everybody else is aware. We don't have anybody new, do we? All the same crew. Okay, good. All right, let's go ahead and discuss the minutes from our last meeting in May 14. Is there any discussion for the May meeting minutes? If not, do we have a motion to approve the minutes as they are written?
I so move.
Second.
Okay, we have a move and a second. All in favor?
Aye.
Okay,
I think
well,
that was Sheila that made the motion.
Sheila made the motion.
Second by Anthony.
All right, now we are ready for Bonnie Doss to give us our financial update. I've asked for a roll call of the people on the phone that can't hear me, apparently.
Amy, before we start,
Yeah.
there were some agenda items that I requested to be on the agenda on May 21st, and I do not see them on the agenda.
They are under that bottom number 7, comments, suggestions, and next steps. That's where we'll do anything that's requested by a board member or by a committee member to be discussed. That's the way I understood it. So when we get to that point, when I ask for comments, that's your shot. That's your chance to bring those issues up. Are we still waiting for the telephone group to be able to hear me?
Is there anybody on the telephone that can hear me?
Yes, I can hear you, but Amy, I can barely hear her. It sounds very low, and she keeps breaking up.
Nadia, I think this is being live broadcast. Can you go to the YouTube page for that?
Okay, we are ready for Bonnie Doss to give us our financial update, please, Bonnie.
Okay, Nadia, can you move the page for me?
You got to get right up at the microphone.
Nadia, can you move the
Okay.
page for me?
Okay.
Next page. Next page. There. Oh, stop. Okay. Here we're looking at the month of May on our financials, and the operating revenue is flat as it's been all year. But when you go down to the expenses, let's take a look at them. Our administrative costs are a little low in April and May, and that is because we had the premium holiday from Cigna in April and May, also February. It runs about $237,000, so you can add $237,000 to the month of May to know what our normal admin expenses would have been. Our clinics are running flat, but what the notable thing is for this month is our claims are also running flat. And a lot of people expected our claims to run low this month because of the COVID-19, but this is telling me, since the expenses are flat, that what's running this are the people, the chronic people who are high claimants who really need to use our hospitals. You know, they're still using the hospitals, so that's why the expenses are flat. We had a decrease in operations of $699,000 as compared to last year, $233,000. And we end a fund balance of $6.7 million as compared to last year of $13 million. Any questions?
Okay, thank you very much. We're going to move on next to the non-tobacco incentive program. Lucianne? Is she there? Yes, there she is.
Can you hear me?
Yes.
Okay. I'm a little shorter than the mic, but it says not to touch it. So Nadia, can you turn the slide? A few months ago, there was a vote to add a non-tobacco surcharge / incentive to the tobacco smoker surcharge or incentive to the program. And what we have done is put together how the program would work. And just to go back a little to remind everybody, I mean, we all know what tobacco use is. And, you know, cigarette smoking is the most common form of tobacco use. However, we are recommending that all forms of tobacco be considered under the program, and that would include anything that's sniffed, sucked, chewed, vaporizes, e-cigarettes, and other electronic nicotine delivery systems, or called ENDS. And we're all aware about the economic costs of tobacco. They're substantial, and it affects our health care. And secondly, secondhand smoke is also extremely dangerous, and it causes similar illnesses as a primary smoker. So the one thing to consider is, what is a tobacco user? So if we recommend all products, it's everything that I've mentioned earlier, and we also have to talk about a look-back period for a person to be considered tobacco-free. So look-back periods vary amongst employers. Some do 3 months, some do up to 2 years. And we're recommending a 6-month look-back period. So therefore, if you're, and I'll talk about open enrollment in a minute, during open enrollment, if you say you're tobacco-free, you have to look back 6 months to say you're tobacco-free. And that would include any of the delivery systems that I mentioned earlier. Is there any questions on that?
So, yes. So are we using a 6-month look back
Yes.
as a definition? Okay,
Yes.
thank you, I'm sorry.
Okay. Next slide, Nadia, please. So the recommended approach is, we've had, and you may have seen a part of this slide a few months ago when this was presented, but we're going through. We did phase 1 already. It's completed. It's the discovery phase, and there was a SIAC vote to have an amount of $50 per month for a smoker, a tobacco user. I will use that term. And so we're on to phase 2, developing the program. And a policy would need to be in place for existing employees and new hires. New hires, that is a little different than, and I'll get into the program itself, but the way you have to structure a program is you have to have a reasonable alternative for the employee in order for them to complete a program within a reasonable amount of time, and it has to be something that's not burdensome on the employee. So the employee will have to complete, if they are a smoker, 6 smoking cessation sessions. We'll go into that with, and it'll be through Cigna. And the reason new hires are treated maybe a little bit differently is because they're going to become, if they're a new hire in October, well, they're not, and it's on an annual basis. I should step back and mention that, the program. If they're a new hire in September, October, then they really don't, they may not have a reasonable time to complete the program in those last few months of the year. So as a new hire, they would be considered they would obtain the incentive for those few months, but then go back into not having the incentive after that time period, starting at the beginning of the year. I know it sounds a little complicated, but it's what we're doing there is making it within what we have to do for the employee. And we don't want to put any burden on the employee with doing the program and having them only have 3 months to complete a session because they're a new hire at the end of the year. And so the reasonable alternative program, that's the second bullet under in progress, is the Cigna. They have a program, and it's the Lifestyle Management Tobacco Cessation Program. It's currently in effect. There's nothing that needs to be turned on. It's a free program, and it started back in, I believe, and I know the Cigna folks are on the phone, I believe it was 2015. So it's there, so nothing has to be done with the program. And you actually do have a few members enrolled in the program today. So the other piece of it is a communication plan. Cigna has a lot of communication material, but this is important to communicate to employees. If they are a smoker and they attest to being a smoker on their affidavit, their premium will be higher than if they are not a smoker. Does that all make sense?
But if they choose to join one of the programs, will they still be charged?
They will be charged the premium until they complete those 6
Until they
sessions,
complete.
and then the premium will be refunded. And I'll go back to what I mentioned earlier about those late hires at the end of the year. The money has to be refunded before the end of the year. So if they were completing a program at the end of the year and it was going to be December 30th, well, you would not have, BPS would not have the opportunity to refund that money prior to the end of the year. So we're looking at, you're starting in January with the program, you have until September 30th to complete the program. And when you complete the program, that $50 per month will be refunded to you.
Is the only program that applies to this the one that's offered through Cigna, or do our well care clinics offer a smoking cessation program that will qualify?
So I'm not sure about the well care clinics, but I know that it's Cigna through Cigna's program and also through your on-site. And I cannot pronounce Joni, but I don't. Devonport, Whalen?
Yeah, let me take that. Joni is going to be providing that in the well care centers.
Okay.
So it's kind of one and the same, but it is Cigna's running it. The reason why we're going through Cigna is it's easier from a tracking process, because that's how we'll know directly whether someone's completed all 6 courses or not. Because I think they can also do it telephonically as well. So they can do a telephonic smoking cessation course. They complete 6 of them, or they meet with Joni face to face in one of the clinics, and that's kind of how that's the approach that we felt was best.
And obviously, when any program is put in place, there will have to be legal review of the policy because you are adding it to your program. And then phase 3 will be deliver, and the program will need to be offered every year, which it already is. New hires will be required to complete the affidavit upon enrollment, and the communicating the program with existing programs, and as Mark mentioned, it'll be through the clinic, and as a matter of fact, right now there is going to be a communication campaign even before this that Cigna is going to be emailing some members just to give them some background on, like, there are teens that think vaping is fine, but to let the parents know that really that's considered smoking and it's really bad for you. So we're going to be starting that earlier, not on January 1. And so I'm going to go to the next slide. Okay. So I mentioned earlier that we are in phase 2. That's the currently in, and phase 2 is 3 steps: communicate, engage, and measure. So we're referring to the surcharge as an incentive or credit. And the reason for that is, I think it's the connotation of it. If somebody is a smoker, and rather than say, if you tell us you smoke, you're going to be charged $50, it's you're going to be charged the $50, but if you don't smoke, you'll get that back. So either way, it's there, but it's how people perceive things. An employee must complete the affidavit, and we have a sample one in the presentation, certifying the tobacco status, and that's the 6 months. And there's like an XX in the presentation about the date, and it will need to be determined based on open enrollment dates. And I know that we just have those, and it could be the end of the open enrollment period. And
Can I say something, Lucianne? I want to clarify what happens. During open enrollment, when people sign up for benefits, they will be asked certain questions, and that will be one of them. Do you use tobacco products? If they answer yes, then they're going to be considered a smoker for these purposes. If they answer no, they don't even, it's not part of it at all. They move on, and there is no tobacco surcharge. Does that make sense? So everybody's going to be asked that question at open enrollment and as they come on as a new employee. Any questions about that?
So
They just-
optically, you're going to put the rate, the higher rate as the rate, and then the
Yes.
incentive non-smoker rate will be the lower rate.
That's correct.
We're not
correct.
going to call it surcharge, we're going to call it an incentive non-smoker.
That's correct.
Got it, check.
And quick question, what about spouses and children? Are we going to be asking a question about them too?
I don't think we address that with the SIAC committee on whether you want to have the spouse or not. So we are doing this for the employee at this point, unless the committee would like to include spouses with that.
That's a hard road to go down.
It is.
To me, if the employee's going to cost more money because they smoke, so is any other
I know.
beneficiary. So I would think you asked the question. All we're doing is an affidavit. So to me, it's just another question, another line on paperwork.
We're willing to look at that. Does everyone, I don't want to ask I guess I can ask a vote. How many would like that to apply to both the employee and the spouse? you give
Can we
me-
have discussion on that?
Sure.
Before we vote on
Absolutely.
it?
Yeah.
I would just say this is a new program, and let's see how this goes before we start trying to expand it out.
I'm concerned, I hate the word optics, but since we're talking about optics, it's gonna look like we just raised everybody's rates $50, right? But if you don't smoke, which is the majority of our employees who are using this, you're getting that credit back.
Well, we can't hear any.
Oh, okay, sorry. So if we say, and spouses, then is it going to look like we just raise the rates $100 and we're going to give 50 back each? I mean,
No,
how does the logistics of that work? Or we just say you're not going to get the $50 credit back if someone in your household, an adult in your household who's on your plan is a smoker? Is that where you're going, Jeff?
That was my thought process, that for the $50 incentive, that everybody on the plan should be tobacco.
Okay, got
So
it.
To me, that's what makes sense if we're going to do it, but I defer, obviously, as far as BFT, I defer to Anthony on this a little bit too, as far as what he sees on it. That was just an observation I made.
Would the question only be that your spouse that's covered under our plan
Yeah.
be a smoker? So not, does your spouse smoke?
Right. Any
It would only
adults
be if
that
they're
are-
covered under the plan.
Right.
I mean, the question could be, do you or your spouse on the plan use tobacco products?
Or could we just say, do you or anyone else covered on the plan? Because we have some that are.
Teenagers,
I
adult children.
I would
Sure.
agree with that. We have a massive issue with regards to vaping, and especially with children under the age of 18. It is becoming a very, very serious health concern. So I would be in favor of having anyone that is covered under the plan participating in tobacco products. And then it would be just one singular $50.
not per
Yeah,
person.
I wouldn't recommend $50 for every person.
Correct.
I don't know how
We're
I can get
speaking
any
directly into the
closer to the
microphone,
microphone.
I don't know what's going on.
What are the thoughts? Do you want to think about that and come back and we can take a vote or get everybody's thoughts in general, or finish this presentation and come back to that thought?
I think we want to send a clear message that we see that that's causing cost to the plan. So as we're going out with this, I believe everybody should be responsible for what's happening in their household.
I concur.
Quick question, because I don't cover a spouse. Does the spouse also have to do an affidavit? Or, sorry, the assessment, or is it
It would just be the employee
Okay.
doing the affidavit.
Thank you.
The spouses do, however, do their own biometrics. So then we come to the question of, what if the employee fills out the paperwork and says, yes, no one who is covered under the plan uses tobacco?
The question needs to be, to the best of your knowledge,
Right,
does
yeah.
anybody in your household on this plan?
Right,
Because
right.
your 17-year-old might be vaping and you have no clue.
Right, right. And I don't think we penalize people for that, because I know
Right.
that's happening. But, you know, let's say the spouse goes in, does their biometric screen and says, yes, yes, I smoke, you know.
What are the wishes of the committee?
Is anybody opposed to having a vote right now? Let's ask that question. Okay,
No?
so what do you propose the vote be? What language?
Yes, but put the tobacco surcharge based on the household, or continue with it as we had planned for just the employee?
That's two different things. Should the question be, are we approving
Well, yeah.
adding the entire household to the affidavit question?
Yes, that's a
All right.
good way to go.
So let's go around and take a vote. We'll start with you, Sheila.
Yes. For
Yes.
household.
Yes. Yes.
No.
Yes.
Yes.
And me, yes?
All right.
Oh, wait, we have people on the phone. Dawn, can you hear us to answer?
And if you can't
Maybe.
talk, say yes or write yes or no maybe in your, communicate it that way.
Can you hear better when I talk, Nadia?
Yes, I can hear you, but everyone else in the room, very, very hard to hear.
What is going on?
Ask her to communicate with Dawn on whether she wants the tobacco surcharge to apply to the family.
Can you communicate with Dawn and ask her if she wants the tobacco surcharge to apply to the family? Or maybe Dawn heard me. We can hear you.
They can hear that mic, but they can't hear us. They can hear discussion.
She says yes.
Okay.
Dawn says yes.
Okay, thank you. So it is unanimous, except, well, I'm sorry, it was not unanimous. There was one vote no.
Okay.
Dawn just texted me. She said, I can hear you now. Yes, that is my vote. Okay. Okay, so go ahead, Lucianne. I'm sorry.
Okay, thank you. We kind of talked about the engagement regarding the Cigna's Lifestyle Management Tobacco Cessation Program, and it includes nicotine replacement therapy and the 6 coaching sessions. There are more coaching sessions that can be done, but we're saying for the program, a person has to complete 6 of the sessions. Person can continue with the sessions.
Does the program include the offering of drugs like Chantix or anything like that as part of the?
I know it's nicotine replacement therapy. I think Corey's on the phone.
Okay.
I don't know if she can hear me. Corey, are you there?
Yeah, Corey, can you answer that? Sorry, I was on mute. Yes, Lucianne, do you mind repeating the question?
Does the nicotine replacement therapy include the drugs such as Chantix, et cetera? Did we lose you, Corey?
Oh, okay, so, I'm sorry, I just, so they can work with the Telephonic Tobacco Association program, Signa, to work with those right on the site, even if doing it telephonically, posting now. Both programs have access to nicotine replacement therapy.
And I guess the question
No
is,
matter which option they choose, they would have that available with that alternative. They remove that tobacco.
so Corey, the question, I apologize for interrupting, is what kind of nicotine replacement therapy it is.
What type of therapy?
Yes.
I would have to come back and take that away.
Okay. We'll get an answer back to you.
Well, I think she did say nicotine replacement was
Right.
included
But
in
does,
the
is
therapy.
that
It might be
oral
a patch,
medication or is it a
oral.
patch? Is it gum? Is it, because there's a difference.
This is Dawn.
Yes, Don, go
Can you hear
ahead.
me?
Yes, we can, very well.
I really think it's important if we're gonna have the options for sensitization that Chantix and bupropion should be available for at least a couple of times. So, when they say, yeah, there will be things, the things may include, the nicotine patches, but, everybody's different, and those two particular drugs, Chantix is over $200, bupropion is like under 20, so it's not that expensive, but, if they're using it for smoking cessation or giving it an attempt, my suggestion would be that those things would be at no charge for either X amount of time or X amount of refills, just a suggestion.
Don, what was the first or the second drug? I hear Chantix, but what was the other one?
Chantix is the first one. The second one is actually Zyban, but I actually saw this drug, so I know what the deal is. But Zyban is basically Wellbutrin, it's the same exact thing. And the generic of bupropion, either SR or XL, will end up doing the same thing. And it's very inexpensive, and it does work for a lot of people. It works on the addiction center in the brain, and it makes cigarettes taste bad, actually. So, again, you need like 5 to 6 attempts usually on average for people to quit smoking. So giving them all of the options to do that, I think, and not just saying, oh, we're going to give you something and yeah, but the only thing we're going to give you is nicotine patches. I don't think that's really enough if we're really focused on helping them quit smoking.
We will look into that and report back to the committee.
We'll take that as a takeaway. And I did just want to clarify, Don, you just brought up a good point on quitting smoking. So with the programs, they don't necessarily have to quit. It's just going through the coaching program. So I just wanted that to be clear. Completing the program does not necessarily mean that they quit smoking.
The goal is that
Okay.
we want them to quit smoking.
Lisa, can you speak into a microphone, please, so everybody can hear?
To that point, if someone goes through 6 coaching sessions with Joni, which is delightful and fun because she's terrific, and they don't quit smoking, they get the $50 back per month, $600 back per month. They didn't quit, and we still have a smoker on the plan, so what have we gained? I didn't know about this alternative plan until Lucianne presented this, and this has to be a feature of the plan. And I see this as being a huge out in a way that all of the things we thought this would be good for won't be. There'll be limited revenue to the plan with the extra surcharge, and you'll still have smokers. So I'm now not so sure how effective this will be.
But when we come back next year.
That's a good point.
So when we come back next year, though, will they get that
This is
same
Dawn. I'm not sure who
opportunity
just
over and
made
over?
that statement, but I think it's a culture shift. So, I mean, I understand what you're saying, that these things could cost, more money up front, but when you start doing these types of things, it's, if you're a tobacco user, you're going to end up paying more for insurance now or down the road. But people start getting the hint. And it's just like, when taxes go up on cigarettes, less people smoke. So, all of these steps are kind of getting us there. And I appreciate the expense of all this, but I think that even new people then that come into the district realize what the policy is going to be, and you're going to say, you can smoke now, but just so you know, that's going to cost more for your health insurance. So people kind of get the culture change.
That's my point, though, it necessarily won't. If they simply have 6 sessions and say, I completed the alternate plan, and I'm going to keep smoking, they get their money back.
Yeah,
There is no penalty.
Well, the DOL requires it, so the reasonable alternative, so it's,
And I didn't know about it at all till
Yeah.
now.
I think that's Lisa. It's Don. I mean, I get what you're saying. I do. And they could kind of game the system. But again, it's almost becomes a culture and a peer pressure thing because everybody else on the plan also knows that all these things are costing money. So I don't want to say you guilt these people or, smoking shame them or anything, but I think that kind of starts happening organically.
Is there a stipulation in the language that you can only participate in the 6-session procedure maybe twice before, like almost like 3 strikes you're out? Like you do it 6 sessions, get your money back 1 year. Next year you try again, you do 6 sessions, get your money back. Year 3, I'm sorry. No, you don't get to play that anymore.
Lucianne, is there?
Well, I was going to actually say that we will need to check on that because I know you have to offer the program every year.
For new
So
people.
they would go through the same process every year, but you're saying a limitation.
Yeah,
And
like-
I'm not sure if you can.
So they would go through the same process every year, but they're saying a limitation.
It's a delay. You're hearing
It's
yourself
you.
on something.
Lucianne, this is
Please,
Lori.
please mute your microphones if you're not speaking, if you're on the phone, because we're getting feedback.
I'm sorry, I just turned it off. I can't hear everybody, so I have it on the YouTube as well. Apologies. Yeah, so with anything that has a tobacco surcharge, it has to have the alternatives offered every year to allow people to participate to earn back that money or to have that removed. So they would have the option to still do the coaching program with telephonically on-site as well as the physician waiver. So there always needs to be an alternative offer. There's no cutoff timeline.
I understand that it needs to be offered every year for people who are first-timers, maybe even second-timers. But, I can foresee 4, 5, 6 years down the road, people playing it like a game. Yeah, I'll go to my 6 sessions, I'll get my money back, it's no big deal. I'll do my 6 sessions next year and get my money back, it's no big deal. And they just play it like a game instead of genuinely putting in the effort to stop using tobacco to save the plan money and for the betterment of their own health.
I think for the purposes of our meeting today, I'll ask Lucianne to research that and provide that in the next meeting, because I don't want to get into a whole lot of discussion about that. I think the point of the tobacco cessation program is to try and get people to change their habits to become healthier. And yes, there is a chance that people could do exactly what Lisa has talked about, but I think it's something that I think we need to do, because if we can get people to stop smoking, the chance of them costing the plan money and affecting their family will be reduced, because smoking does cause several different types of cancer, and I think it's worth the effort. I mean, I personally do.
Well, and while there may not ultimately be a financial cost if they get the money back, it will be a pain. It'll be a pain to have it to begin with and then go through the process every year of getting it back. It will be a pain to have to schedule 6 sessions every year. So and have to listen to people tell you things that you already know that you don't want to. I mean, hopefully we're water over rock, wearing people down to will to quit, So I think it's still a good point, but it's not completely without cost for them because of their time and effort that they'll have to go through to do that every year.
How long does a session last?
I'm thinking it's about an hour, but I can bring that back too.
I think it's about an hour. But and Signa, I know you're on the line, Corey, but this session isn't just I called you and I talked to you for 2 minutes and I hung up the phone. That's not considered a session. So they have some parameters around that. And that goes down to, we talked step 3 measure, and Corey already mentioned that quitting tobacco is not the requirement of, your 6 coaching sessions. Hopefully that will help. And then the last thing is, and Mark mentioned this earlier, is the reason this is a great way to go is because Cigna's going to track all of this for you. And then get back to Brevard and say, okay, these people, they've completed the program. So they're going to be doing more of the maintenance administrative work on that. Anybody have any more questions on that before I go to the next slide? Next slide, Nadia. Okay. Maybe I lost Nadia.
This is Kelly. Can you hear me?
Yes.
Just wanted to just speak to what Dawn was asking about. And Corey, I can't, but the bupropion is covered because it's generic. That's covered through the PPACA requirements. And then the Chantix is part of the BIF. So currently it's covered, but not at zero cost share for Brevard School members. But we do expect a generic, potentially this year for the Chantix. And once that's generic, it'll be under the PPACA. But we can certainly look at making it zero cost share if that's something to consider if it's not available generically by the time this goes into effect.
Thank you, Kelly. So I'm not sure if Nadia is hearing me or trying to get to the next slide, but the next slide talks about the methods of self-reporting and affidavit, and just some information about Aon had done a healthcare survey, and 70% of the respondents used self-reporting, 18% require an affidavit. And between both of those, you will have employees that are dishonest. That will happen. And I don't know if anybody knows really a way around that. And it's unfortunate. Next slide, Nadia. Mark mentioned earlier about some communication language, and in some of the opportunities, you can just simply put it, simply there'll be more explanation, but you can receive a $600 discount on your 2021 medical premiums by signing a tobacco-free affidavit during annual open enrollment, or by completing 6 coaching sessions in Cigna's Lifestyle Management Tobacco Cessation Program by September 30th, 2021. And this will all be online, and then the worksheet will ask them to say, I certify I have not used tobacco products, and we're using 6-month look back. We have April 1 down there, because I think open enrollment, I'm not sure if it ends October something, so it'll be 6 months prior to open enrollment end date.
Can I make one suggestion?
Sure.
Can we keep the language the same in the enrollment guide and the question? It says you can receive a $600 discount, and then in the question, we're calling it a tobacco incentive. Can we use the word discount and discount?
Sure.
Or incentive, just for consistency, so as not to confuse people?
We can use credit as well, which I don't, whichever way.
I like the word discount.
Discount?
I think it's clear and easy. Yeah.
Okay. Not a problem. And then the next slide is just an example of an affidavit. It's not custom to you. We've changed a couple of little dates in here and the program, but on the left side, it defines the tobacco user, and on the right side is the attestation. Have you used tobacco products of any kind in the last 6 months? Are you a tobacco user enrolled in or willing to enroll in the Cigna Lifestyle Management Tobacco Cessation Program through Cigna? And then there's misrepresentation. There are a couple of bullets there. And just remember, this is a sample. So one of this is loss of eligibility for the plan, repayment of any incentives, and discipline. And I know that you have an affidavit for your spousal surcharge. So you may want to have the affidavit be similar to, those bullet points be similar to the spousal surcharge affidavit. So there's not any mixed messages there.
So this is something that we would customize for our own use. We're not recommending this language?
What this is some other employers have used this language, so it could be customized. Any other questions?
On the slide previous, this page and whatever the affidavit example, whatever we model that after is very clear. Have you used it? Yes, no. Are you, program? But the question at the bottom of slide 12, the open enrollment worksheet question, because we've got a negative and a yes or no. Yeah. If we can word that to be super clear, because I think if people are going fast and it says, I certify I have not used tobacco products, then me as a non-smoker, I would click yes. But I would have a hesitation to go, okay, does yes mean I do smoke? Yes mean I don't
think it
smoke?
needs to be two separate statements. Like the first one says, yes, I have used tobacco since April 1st, 2020. Second checkbox, no, I have not used tobacco since 2020.
It needs to be
And then you
crystal
pick
clear
which box
so that,
applies to you.
right, because we don't want to trigger something when someone actually is a non-smoker.
Completely agree. If somebody clicks the wrong box, that's.
We will make sure that will be part of our enrollment.
Painfully obvious, yes. On that affidavit example, over in the right column, about 2/3 of the way down, the bullet that says discipline under the company's code of conduct. Anybody else have a problem with that?
Well, I think that's what she's saying. We can make it the same as we do on the other one.
I think that's something we need to discuss.
And that's why I was recommending using the same bullet points that are in your current spousal affidavit, because everybody's already seen that.
Right.
So it would be the same points.
Okay.
Are there any other questions? Well, thank you for your
Lucianne.
time.
Yeah. Up next, Brian McNeil is going to give us our Cigna quarterly medical update. Brian, are you on the phone? Brian, can you hear us?
Brian, it's your turn. Please make your presentation known.
Okay, I'm speaking. Can you hear me now?
Yes. Now we can hear you.
Okay. Yep, I didn't have it on mute, so I'm not sure what happened. Okay, hi everyone. Thanks for your time today. Just going to give a real quick 30-minute overview of the most recent quarterly review that we had with Mark and team. Well, I guess before we get started, as you'll see on the front period is April of 19 through March of 20. And the base period as we look through these reports will be the prior year, April of 18 through March of 19. Okay, so with that, you can see the executive summary page, and I'll try to point to the areas here with my mouse here. So on the lower section, you can just see your membership has decreased slightly from last year, less than 1%, down to 11,621 total members. Your average employee age is just under the age of 49 now. Your demographic factor went up just a little bit from last year due to the increase in age. That's still lower than the school board norm. You can see your total spend, dollar spend, plan spend, meaning employer and member cost share combined. You can see the medical went up 5%, the pharmacy stayed last year to this year, and total plan spend is now up about 4% from a year ago. Cigna's trend, medical trend, and pharmacy trend combined is about 7.5% year over year, so you're below the Cigna trend that we typically see in the Central Florida area. But when you adjust for that, for the membership changes up above on a per member per year basis, you're now paying out about $6,400 per member per year, which is up from about $6,148 from last year. That's a 4.6% increase, and again, well below trend. And you can see other school boards that have Cigna across the state of Florida are running at about $7,500 per member per year compared to your $6,400. So that looks like to be a pretty good stat. And you can see your catastrophic claimants that exceed $100,000 per year per 1,000 members went up about 11%, from 6.7 members up to 7.4 members per thousand. The norm is 7.8. You can see the plan spend for the catastrophics per member per year is at $1,500. It's below the norm of $1,900 and up about 10% from a year ago. But your non-catastrophics are only up 3% per member per year. So those catastrophics are really what's driving that 4.6% increase year over year. Okay, now on the right-hand side, lower right-hand side, your population health and pharmacy. You can see that about 45% of your members now have a chronic condition. The norm is 47.7%, and they drive about 74% of your total plan spend year over year. And you can see your total health engagement is about 58%. That's above the norm of 39%. So we have decent engagement, although it's down a little bit from last year. It's still pretty good compared to the other school boards that we have. The preventive utilization is right about 55.5%, a little bit below. The completion is below the norm as well at 45.8%. And health assessments, the online health assessment that your enrollees take is at 61%. That's down from a year ago, but well above the norm. And then the gaps in care rule compliance, what they should be doing based on medicine-based evidence guidelines, is about 80%, and that is right at about the norm. And we're going to do a detailed deep dive into pharmacy next month, but I saw this real nice increase in your generic dispensing rate by 2.2% generic dispensing rate now. Okay, so I thought that was a good stat there as well. So going to the next page. For some reason, this demographic summary is the same as this next page by relationship. This demographic by summary typically shows you how much spend by age band, and no surprise, the older we get, the more medical conditions we have. So this slide would typically show for that heading that the age band of 65 plus who are still employed, actively employed at Brevard schools, is running about $13,100 per year on average. And the age band of 60 to 64 is running about $10,058 per member per year. Okay. Now let's see if I can get this centered better. There we go. By relationship, you can see the spouse is the most expensive spend on average by relationship at $9,700. That's only up about 1% from last year. Now, we saw a big increase in the dependent spend from $3,000 to $3,600. It's still below the school board norm, but it did make a significant increase. And when you exclude the catastrophics, it did go up the most as well by 5%. So they're running, excluding catastrophic, about $2,600 compared to the norm of $2,700. And you can see the spouses are still the most expensive relationship at $6,700, about $6,300 for other school groups. Looking at what's driving your trend, as we mentioned earlier, the catastrophic. So really, if you look at this total trend, contribution of 3.8%, catastrophic makes about 2.2% of that. And then about 1.3%. So those two categories are really what's driving your trend over here. And you can see, again, net to you, the employer, what you spend on medical, everything included, including the catastrophics, which went up 11%. All that went from $4,100 per member per year up to about $4,300 per member per year. Again, below the norm, but up about 5.6%. And then when you include this pharmacy, which have really good numbers from year over year, you're up less than 1% in pharmacy in total. Net to you, the employer, brings that down to that 4.6% that we talked about. And then I dropped in here, again, what the norm is for other school boards for total plan spend medical and pharmacy plan spend, those two combined, is $7,400. That's 16% higher than where you are at $6,400. You're looking at your spend by condition. Your most expensive condition is cancers, neoplasms. It's up about 1% from a year ago, to $748 per member per year. The utilization for those that have cancer is up about 2.8% from last year, and the cost is up about 4%. You can see the top 10 here. Neoplasms was number one, musculoskeletal number two, gastro was number three, circulatory, then general medical diagnosis. And you can see the other conditions that round out the top 10. But in general, you're up about 5.6% per member per year in total cost. Utilization's up 1.2% for those conditions, and your cost is up 4%. Again, medical trend runs about 7.5%, so you're below what we would see for medical trend for those conditions. Looking at your catastrophics, we did mention that you had an increase in the number of catastrophics over $100,000. That's the category there. Your spend, though, is actually down just a little bit from last year, from $190,800 to $190,300 on average. And then breaking out the high-cost claimants or catastrophic claimants by category, you can see a 22% increase was the largest increase, and that's in the professional component. The next highest category was inpatient at about a 16% increase. That's the 10% overall increase by category that we talked about a little while ago, and it added 2.2% to your trend of 4.6%. And again, your non-catastrophics are only up 3%. But looking at your top 25 claimants that exceed $100,000, it's kind of hard to see that. I'm sure it's pretty small, but your largest claimant is a normal newborn or a newborn that ran about $1.4 million. I ran this report in May, the end of May, and they were no longer on the plan as of that time. Their last date on the plan was March of 2020. I'm not sure what happened to that newborn. Their last date of eligibility was March, and you can see number 13, it appears, is no longer on the plan as of August of last year, and then also August of last year, number 21, no longer on the plan. But the other 22 rather, are still on the plan time I ran this report. And out of your top 20, looks like 13 of them were employees, 6 spouses, and 6 dependents, for a total of 25. Okay. I did not show their age on this one, so you wouldn't have to try to hide that a little bit for you. Okay? Any questions so far? Good. Okay, looking at your inpatient information, per admissions per 1,000 and bed days per 1,000, your admits went down and your bed days stayed exactly the same from last year over this year and well below the norm. And you can see the typical cost per admission is about $25,700, a little bit lower than the school board norm, and your cost per bed day is about $5,500 per day, and the school board norm across floor is about $5,600. Looking at your costs from an outpatient perspective, you can see the actual surgeries per 1,000, diagnostic tests per 1,000. Actually went down for surgeries and up a little bit for diagnostic tests. We'll go into the ER urgent care in more detail, but that looks to be a slight increase per $1,000. And on the bottom left-hand side, you can see the typical outpatient surgery now runs around $3,300, a little bit higher than the school board norm. A diagnostic test, about $202. And ER urgent care combined in total is running around $500. School board norms are around $1,000. And I think that real good preferred health center contract that you have in Brevard County, where you get a lower reimbursement rate than Cigna's typical, you out on as far as your total cost when you include urgent care. Now, looking at the ER and urgent care opportunity, this top line here, these non-steerable, those are actual ER visits where we really couldn't have steered them anywhere else but the emergency room. They really needed to be there. You can see the actual cost, though, actually went down about 2% from last year for those people who showed up at the emergency room through March of 20. The steerable ones, however, would be those type of visits that showed up at the ER that could have possibly been steered at an urgent care. And this $830, we break it down for you here in this table below, these 180 visits that showed up at the ER that could have possibly been done in urgent care. And again, 98% of those people live within 5 miles of an urgent care location 2. And so we try to reach out to them and remind them of their options to go to another place of treatment if they can. But you had 50 musculoskeletal visits at the ER that cost about $850, which could have cost $124 on average at the urgent care. So there's a real big opportunity savings here that if only 25% of these steerable visits went to the urgent care, it would have saved Brevard Schools about $32,000.
Brian, what kind of...
about $64,000 roughly in savings. Okay, just to give you some information on that.
Brian, can you hear me?
Office visits,
Brian?
these are the primary care and specialty care visits. The number of primary care visits went down, at least that we show in our reporting. You could have had an increase over at Marathon Health. The specialist visits went down as well, and then you can see the total per 1,000. The typical primary care visits around $136. That's all inclusive. It does not, and it includes the member copay. So if you take that out, the member cost here of $30, it's really costing you about $106 for a PCP visit, and a specialist visit's around $181 in total. That's down just a little bit from last year and also lower than the school board norm.
Brian, have a question for you.
Yes.
When you talk about the steerable visits, if you would go back to your last slide. What is Cigna doing to educate those folks who are going to the emergency room rather than going to the urgent care center? What type of education are we doing?
Yeah, we identify those marked out, for lack of a better term, frequent flyers. And if they go at least 3 or more times within a 6-month period for something that's not real urgent, we send them a notification, just reminding them of their options to go to an urgent care facility and give them some locations in their letter. What we found out happening, I'm not sure if this is happening in Brevard County, but in Orlando, some of the hospitals that advertise on the billboards, 15-minute wait at the ER or less than 10-minute wait, they're not balance billing the members for an ER visit. So these members know they can go there, almost like a PCP visit, knowing that the emergency room is not going to balance bill them. So we're working with the hospitals to make sure they honor their contract. They're supposed to balance bill. They need the balance bill, so we're working with them on that. I'm not sure if that's happening in Brevard County or not. That's one thing we started noticing over in Orlando. For ER visits. But Mark, we are reaching out to them and trying to steer them and guide them as best we can to use urgent care. I know you advertise that and educate them as well, especially during the Christmas holidays and also during open enrollment.
Is there a chance to do it in less than 3 visits? So for example, if they go a second time, do that education rather than wait till the 3rd?
It's an automated process, Mark. It's going to be 3 visits in 6 months.
All right, thanks.
Yeah, it's already set up.
Can you even, I don't know if Brian can hear me, but can we even get a specific, I'm just trying to think, can you hear me? I'll tell you my question.
Hold on 1 second, Brian.
And then maybe you can communicate to him. Can we even get as specific as saying, hey, because Cigna can do that because they have access to their records, say, okay, on this visit on such and such date, this is how much it cost you. If you had utilized X urgent care, it would have only been this. Something really tangible. Can we do that?
Mark, you have to re-ask that question because I could not hear that.
Okay. What the question is could we provide some education that says, had you gone to this urgent care center, this is what it would cost you in the plan, versus what you actually spent. Did I say that correctly? Is that possible to do, Brian?
Yeah, we have those materials right now today. We do, as part of our normal education. I think Corey can send you an email blast that we could send out that reminds them if you situation versus urgent care, this is how much the difference in cost is. Right, Corey? I believe we have that.
Yes.
I think because you said it's an automated function, I think we need to talk about that and see if we can't do something different in that area. But I'll get back to you on that too.
Yeah. Okay, ready to move on? So I'm just having a hard time hearing it. I'm not sure if you want to move on yet or not.
Yes, we only have 1 microphone that works for you, Brian, so I sat down and I had to come up here. Yes, move on.
Okay, sorry. Right. Okay, so here's the opposite. Preventive care, you're spending, this is slide 26, you're spending about 2.3% of your total spend on preventive care. It's up from last year and well above the norm of 1.6%. You can see 67% of the children had their well visit completions and 41% of the adults. That's low compared to what we see for the school boards. But you do have some pretty good cancer screening rates. These are at the bottom right-hand side, these measures, the HEDIS measures that we look at for these cancer screenings. You must be in the plan for at least 24 months within these age bands. And your breast cancer screening rate is 71%, which is 62% of the norm, so that's good. Cervical cancer screening is 66%, and colon cancer is 44%. Although it's below the norm, I have seen clients that are a little bit lower than that, so that's not too terribly bad from my perspective. There's still room for improvement on colon cancer screening. Page 27, this is by relationship. So the employees, 59% of the employees have their preventive care, 45, almost 46% of the spouses, and about 53% of the dependents. That's where we got the 55% from. And for well visit completions, it looks like employees were 45%, spouse 35%, and then the dependents had most of that at 50%. Okay. As far as virtual healthcare visits, these are the telehealth visits that we have. You can see a real nice increase year over year. So last year we had 243 unique members. We had at least one telehealth visit. This year that jumped to 529 with at least one visit. Last year 55. This year it jumped up to 133. And then 22 individuals had 3 or more visits last year. That jumped up to 68. So that was a real nice increase in the number of visits for telehealth. And this is through March, so now because of COVID-19, I assume that these will increase significantly as well as we go through the next quarterly review through June. And just some stats on the upper right-hand side, the typical average user of these telehealth visits is right at 40 years old. They also, about 50% of them also had a primary care visit during that time as well. 10% male and 85% female that used the plan. You can see their ages as well, about 34 years old for the males and 41 years old for the females. And we're just saying down here in the middle here, 25% of just 25% of some of your other visits could have been telehealth. It could have saved Brevard Schools roughly $223,000. Okay. So looking at Health Matters Care Manager, this is the new program that we put in place, Mark, for you last year. So you can see the number of admissions avoided, the old PHS Plus program that you were on before. And savings of about $374,000. The new programs, which had more admissions avoided, saved about $789,000. And we had some decertified bed days enhancements as well, or improvements to help you get to that improved savings year over year. It's a utilization management program for inpatient. And in outpatient, you can see last year versus this year, this is the PHS Plus program, which is the prior program. You can see the 2,181 unique members. 2,300 requests. We were able to avoid 680 of these services because it wasn't medically necessary, saving Brevard Schools $1.3 million. There were some that ran over from the total medical cost management in the current period. So 1.3 million, almost 1.4 million last year versus about 2.2 million this year. And when you combine the prior period and the current period together, you went from about 1.9 million in savings last year 2.3 million in savings. And most of that, as you can see up here, was the high-tech imaging savings of 690. That's where AbiCor is managing that utilization and allowing an MRI if it's truly medically necessary, or a CT scan, what have you. So we were able to avoid 672 of those in the current period, saving $695,000 in total medical cost management of $595,000. And most of that is in that sleep therapy, where you can now do your sleep studies at home instead of going to an outpatient facility and spending the night there for your sleep apnea test, if you will. Okay, and that's a savings increase of 20% over last year. Okay, and this is the 139,000 savings that we showed in the prior program. I think it was on this slide here, 139,000. So that savings, again, comes mostly from, this was from radiation therapy, and then the new program is going to be your sleep therapy. That saves most of that $365,000 of the savings comes from that sleep therapy that we just saw in that bar graph. Programs that we have in place that we help manage for you, the cardiology management, sleep therapy, chiropractic services, musculoskeletal pain management, and genetic testing. And then looking at specialty case management, this is where the nurses that specialize in these areas reach out and touch your members that have these conditions or need to be hospitalized. For the prior period in the PHS Plus program, we had 237 unique members with 2,670 interventions. Cigna closed out 339 of them, saving Brevard Schools about $374,000. And in the PHS Plus program, it looks like we had 194 cases. 162 individuals. We were able to avoid, or we engaged, I guess, 284 of those individuals, and it saved Brevard Schools about $791,000. Okay, so last year was 374 versus 791. And cancer care support program, looks like we had a total of 35, and you can see 13 of them are under surveillance and regular maintenance within their cancer treatment. 22 are in active treatment with complications. And out of the 35, you can see that we have 26 of them female, and the average age is 62 years old. And the engagement is 23 out of those 35 are engaged in this program with our nurses, and it's a 66% engagement, which I bolded in green for you because the norm is 49%. That's pretty good engagement. Pretty male and female as well. Looking at the health information line, the 24-hour nurse line, I know that's going to probably be used less and less as we have the telehealth visits continue to become more popular, but you had 50 calls during the most recent period. Looks like 27 of them were redirected to a higher level of care. Only one was able to be redirected to a lower level of care. Looks like it was someone who wanted to go to the ER that we could mention they didn't need to go to the ER and saved the board schools about $1,800. And looking at your engagement, you did have a slight decrease in engagement as we saw on the executive summary, but it is still above the school board norm. And you can see the nice engagement here, 56% for all these various categories for health maintenance and health improvement. Engagement was 58% here. Most of that is in the chronic illness category, which is where most of your engagement is, and it's well above the school board norm, which is nice. And then by condition, you can see the number of individuals we've identified through our claims payment process and been filling out the health risk assessment. Those that we've identified for these programs is about 45%. Your population, the norm is about 28%. But your engagement between health maintenance and health improvement is at 72%, and again, above the norm, so that's really nice to see. Looks like your largest area of depression is 16, almost 17% that we identified, 15.6% with weight complications, and 10.2% for lower back pain. Those two probably go hand in hand, the low back pain and the weight. Okay. Then looking at the lifestyle management program, the lifestyle management includes stress and tobacco, smoking cessation, if you will, and weight complications as part of the program that's free of charge. Because everything's integrated with Cigna, we identified 37% of those of your population for these programs. 303 people right now going through the tobacco smoking cessation program, if you will. And you can see the engagement is about 82.5% in total compared to 7%. And then you can see the well coaching for healthy eating, physical activity, and then treatment decision support as well. Low number of people, but still an opportunity to capture some people and educate them on their alternatives for these types of surgery. Okay. And then when the nurses speak to these individuals that eat, whether they're chronic or not, we want them to set a goal, whether it's healthy eating, improving their exercising, walking 30 minutes a day, what have you. 491 of those people with a chronic condition did set a goal. Out of those 491, 171 of them progressed towards that goal, and 181 of them did meet the goal. And the others that were non-chronic, 47 of them did set a goal with the nurse, 15 progressed, and 11. Then they can see the totals here. Okay, and then this is the telephonic. Only about 5% engagement of those people identified for telephonic engagement were engaged through the telephone, but most of that engagement identified from the other programs that we saw above.
I didn't hear that.
Okay. And then we talked about, Bonnie did mention that we thought that maybe we might see a decrease, a hopeful decrease in claims in April and May due to COVID-19 and the mandatory stay at home. And you thought, of course, elective surgeries were put on hold. So Mark asked me to look at, high claimants from March, April, and May. So I did a comparison of January through March, and this is just a summary of a report that we run for anyone who has over $25,000 in paid claims during that 3-month period. And the report showed 111 Brevard School claimants with over $25,000 in paid claims that totaled $7.5 million. Ran the same report through April, and that increased by 47 members to up to 148 claimants for a total of $10.6 million, which is a $3.1 million increase over the prior period. And then if you go 1 month additional, January through May, that's another 40 members that had at least $25,000 in paid claims, bringing us up to 198 claimants with a total of $14.3 million, which is now a $3.7 million increase over April. So although we did have some mandatory stay-at-home and elective surgeries were put on hold, unfortunately, you had some enrollees that needed to be hospitalized, and we still continue to see their admissions and claims costs come through the program, through May, okay? And then the last page that I have was we've been running a report for the last 3 months. Had the COVID-19 testing and treatment. As you know, they came out with certain codes that we're now able to, process on the claims. The actual claims come in with the actual correct coding for COVID-19. And out of your membership, 160 individuals, at least since January through May, 160 had been tested. 6 of them have been diagnosed as having COVID-19. Out of those 6, we spent $13,800 on testing and $5,200 on treatment, for a total of $19,000. Oh, you see this $105,000. Those 6 people also had comorbid conditions because their immune system was down, probably because of their other medical conditions. And so they've also, those same people had $106,000 roughly in total claims, including that $19,000 in claims in total during that period. So just to show you that they're not the healthy people getting sick, right, or getting COVID-19, it's the ones that have a compromised immune system, which makes sense. And it's just saying down here that we're showing you which codes that we now have that are being submitted to Cigna on the claim forms that we can now process and pay for them. Okay? I think that was it for me, unless you guys have any more questions.
I had a question. Mark, you might need to relay it. Is there any kind of federal reimbursement for the COVID test that we're paying for?
Brian, can you hear me?
Yes, yes.
The question was, is there any form of federal reimbursement for the test that we've made? I believe it's this way, Anthony, but Brian, if you know of a different way, I'd love to hear it. There is if you run a fully insured plan. So that you can submit under the CARES Act, but I don't believe it's available for self-insured. Do I have that correct or not, Brian?
You know, Mark, I want to say I thought there was some reimbursement for self-insured plans too, but let me take that away and see what I can find out for us. Because I know there's asking that same question, and I thought we were able to tell them they have some opportunity. So let me find that out for you, and I'll shoot that over to you.
Right. Okay.
Ms. Butterfield texted that she also has a question. I'm sorry.
I was just going to say, can I get an answer as to when you will have that answer?
Brian, do you know how long it will take to get that information?
I'll try to have it to you by tomorrow.
Okay. Once I get that, I'll send it out to everybody.
Recognize Ms. Butterfield.
Mrs. Dawn, go ahead.
Okay, go back to page 15, and I'm just going to keep, bringing this up so we don't, forget about it and sweep it under the rug. But Brian made a big deal about the generic dispensing. Isn't that great? But we could only go from 92% to 100%. And the difference of that is $352,000, which is awesome, except for our increase in specialty offsets that by $4,000. So no matter how much we go high on generic, the problem that we're seeing an increase in pharmacy at this point are the high-cost specialty drugs. And I just wanted to just point that out because I don't know if it's coming next time. I talked to Tina today that the pharmacy audit looks like it's going to take 11 weeks because apparently they're not getting the data that they need from Cigna. And I'm not sure, Brian, what the problem is there since you guys give it to Aon, but the problem though, starting the audit is getting that data. So that's going to be out there for a long time. But I just wanted to again point it out because there were several other options of what we were doing that we're talking of hundreds of thousands of dollars in difference. That's my only point on that.
Don, just to let you know, what RSM McGladrey indicated that to me last week is the audit will take no more than 10 weeks. They've submitted their information to Cigna, I think this week. So it's not Cigna at this point that's caused that slight delay, but they said they would take no more than 10 weeks to completely evaluate it. Obviously, we're hoping that Cigna can provide that information as quickly as possible. Brian, have you...
We have an audit process in place, Mark, you're absolutely right. Once we get the request from the auditor, we have a certain number of days that we're required to turn that data around. I've been through multiple audits, and I'm not aware of Cigna, taking too long to provide information back. But I'll make sure to stay informed. They do keep me progress, and I'll make sure to keep you aware, Mark, if anything comes up on that front. You're absolutely right.
Just to let everybody know here, we did have a slight delay in starting the prescription drug audit. And the reason being is because we wanted to get some clarification of what exactly the superintendent and some on the committee wanted to see. So that's why there was a slight delay. But it will take no more than 10 weeks. And we should have that. If we don't have it for the next SIAC meeting, we'll definitely have a report from RSM McGladrey on that in not this next month, but the month after that.
And Mark, that's probably right, because Tina was looking at an email from last week, so that's 11 weeks, so 10 weeks makes sense. Right, but it's, so we're gonna see, it's just gonna be a while till we get the data, but in the meantime, we're not being presented other options is my only point to that. But we can move on.
All right. There's somebody else, I thought. Did somebody have a question?
I had a COVID question, if we can.
Do you want to say it and I can relay
Yes,
it?
Go ahead.
Yes.
And it's
So-
related to COVID, Brian.
Yes, so the 160 tested and the 6 diagnosed, is that people who went through their doctors, or is that like it hit anywhere? For example, if someone goes to MedFast, they do ask for insurance information that circulates back, but I mean, is that like everybody who went through something, I mean, are there any that we missed, I guess is what I'm trying to figure out.
The question is on the 160 tests, is that going through their doctors, or would it be any place where the test has taken place and they presented their Cigna card? Did I get that accurate?
Yeah, any place that they went that they submitted their Cigna card and they submitted a claim to Cigna. They went through one of the free testing locations that's throughout the county or over in Orlando, and they did not use their insurance. We would not be aware of that, of course.
Right.
I just on that topic, just to let you know, I was informed that there's a possibility that MedFast would provide those tests at no cost. I've reached out to the manager of MedFast to find out if they would provide them at no cost, and she told me she would have to look at that when she found out we were a self-insured plan. She said that, under a fully insured, they would be submitting those tests as a part of the CARES Act so they can get reimbursed for it. She just wasn't sure about the self-insured plan. That's one of the reasons why I say, as a self-insured, I don't believe we're able to get that, but I'm waiting for her, the manager from MedFast, to get back to me. Because if we can offer that to employees at no cost and no cost to the plan, I think that's a terrific thing. Once I find that out, you'll all know. Yes?
Mark. Oh, I'm sorry. Mark, I was curious, back on slide 15, I did notice that it states that the employer paid was a negative 17.7% variance from the norm. So the employer paid portion of the pharmacy and medical was down. I want to make sure what the definitions again were of the norm for that and what's all included in both the employer and the employee contribution, because the employee portion was up 20%, whereas the employer was down 17.7. And I don't necessarily want, I was going to send this as an email, but I just wanted to bring it to everybody else's attention too, that we talk about that a little bit in the future maybe.
Brian, did you hear that? I noticed you backed up to...
I didn't. I could not hear that, Mark. I'm sorry.
And I'm trying to find out. You were looking at pharmacy, and there was could you say that one more?
It's medical and pharmacy. Slide 15, the first page of it, or first slide of his presentation. In the top right corner.
Okay.
Yeah, it has variance from the norms, or the whole top part there. I think the graph to the left is also pertinent to it. But just to break down exactly what's included in the total plan spend and for that breakdown for employer and employee, and just maybe a quick definition of the variance from the norm. Is that the norm from what we've been doing, trending as our plan, or is that norm from what other plans are doing?
Okay. Brian, if you look at the right-hand corner in the medical and RX trend, the gray box, can you kind of explain what the current PMPY and trend means, as well as from the variance from the norm? Can you describe those in a clearer fashion?
Yeah, so the actual $6,400 total plan spend is actually just your actual plan spend per member per year compared to the norm. So the $6,400 comes from the navy blue section. The center where it says total plan spend per member per month, or per member per year rather. It's just that $6,400, and you have the employer pay $5,500 of that. The difference would be the member cost share, if you will. And you have the total member pay, and then total medical spend per member per year is the $5,062. That's the medical component of the total spend. So you have medical and pharmacy. The medical component is the $5,062. Out of that, the employer's medical was $4,400 roughly, and the pharmacy was the $1,400. The trend is how much it's going up year over year. From last year to this year, that's a 4.6% increase in trend from last year to this year. But you're 13% below the norm. As you remember where I kept saying you're below the other school board norms in these areas. So even though you've gone up a little bit, which is lower than Cigna's medical trend of 7.5%, you're also well below the other school board norms that we see across the state of Florida that have Cigna.
And Jeff, the norms are the other school districts that Cigna has as clients. And how many of those do you have in the state of Florida, Brian?
At least 10 or 12, I'd say, Mark.
And I think a lot of them are the larger school districts have Cigna. So we are showing better than the norm. But did that answer your question, Jeff?
Yeah, I think the point is that the norm is normally the school board's paying more of a contribution to the plan than what are paying out more than what we are, whereas our employees are paying more. So I'm seeing a discrepancy that the board portion is low, whereas employees are paying more. So that's something that I think that we need to look at.
Okay. Anthony, I think you raised your hand. I'm sorry.
Yeah, so being COVID testing came up, I was wondering if we've, discussed using the well care centers for testing. Is that, even logistically feasible? Would it be cost saving? Is it just, are they not set up for that?
They haven't been set up for that. I have had discussions with them about it. The problem is the times they would have to change their PPE, and because every time someone comes in, they have to change that PPE, and I think that's been the problem. But I can certainly bring it up with them again to see if we couldn't do something differently. Maybe even test in the parking lot, which is what some others are doing. But I'll take that as a takeaway, and I'll get back to the group.
Can I ask when?
I'll ask this week and hopefully have something by next.
All right, does anybody have any other questions concerning Brian's presentation? If not, let's move on to communications and education. Lisa?
Thank you, everyone.
Thank you, Brian. Not that he heard me.
All right, there's a lot of information here, so I'll just quickly summarize it. It's pretty well described up at the top on each section, but open enrollment communications kick off with the password letters that go out to all employees. Those are generated by our benefits administration system, Easy Benefits, and they are printed at each site. Each of our local benefit contacts prints theirs for their employees and distributes them individually. The next set of information that goes out, it's our trifold brochure that describes the benefit program and kind of summary level, and with it on the next page is an accompanying attachment that has further information most specific to that particular open enrollment. We are blessed to have a very efficient and helpful print shop that prints all of these materials, divides them up by school sites, and delivers them to the school sites. And they get all that done in about a week and a half. So that distribution is finished about a week before open enrollment starts. The next several pages just kind of lay out the series of emails that go out. It's every couple or few days. Typically, the first couple of emails are more thorough with all the things that have to be done for open enrollment, all the actions that must be taken. Last year, we refrained from using the word passive at all costs, because typically whenever anybody sees that, they just stop and don't do anything. So the focus last year was to say these are the things you must do during open enrollment. You can see that we go every couple days on page 50. That should say September 30th, not the 40th email. That was just to say that open enrollment started that day. As you can see, as you go through these every couple days, it starts the countdown clock towards how many days are left. We actually get down to final hours. This is your last day, because we do have cutoff on the last day at 2 o'clock. So we ask that some of these be posted at the school sites, that our benefit contacts post these around for people to see. They're posted here at ESF as well. And the result is that for plan years 2019 and 2020, we had 74% of benefit eligible employees took action in Easy Benefits during open enrollment. So we thought that was pretty good. It could be quite reasonable that about 25% of folks don't need to take any action, that they're employee-only coverage, they didn't want to make any changes, and so their benefits just rolled and they therefore did not have to take any action. So things may not be so easy for this upcoming plan year. We will continue to do the same kind of schedule of email blasts, the brochure, the accompanying attachment to the brochure, just to give people the detailed information on what benefits they have and so forth. But we are going to be adding some new facets for the 21 plan year that are going to need to be explained and discussed, and have education campaigns going out. So if we do in fact end up with an alternate health plan, we'll need an education plan to figure out how best to tell our folks about that. And if I recall correctly, a couple meetings ago, 3 of our colleagues here volunteered to be on an education committee, if you will. I hope that offer still stands. And just would pause here and ask if you all had a chance to discuss this at all, or if you had any comments on that.
I don't remember.
What do you foresee that committee meeting looking like? When is a better question.
I would kind of ask you that. You had kind of volunteered, 3 of you, to kind of spearhead. So I wanted to, if we want to talk about this offline and come up with a schedule, we can.
I think it's probably a good idea if you would take lead on an appropriate timeline, because you know better than all of us when things need to be distributed and all that kind of stuff. And then, back up before that and tell us when we need to meet and where and how, and then we can.
Have you had any discussions on the approach at all?
No, we have not.
Okay.
Mm-hmm. Yeah, it was just mentioned. It wasn't, nothing formal was created, so.
Well, that's what I said. Does the offer still stand?
Yes, from my
still
perspective,
interested?
absolutely, yes. I'll do whatever I can.
Okay,
help, yes.
okay.
Ms. Butterfield has a question. Dawn, can you hear me?
Yeah, thank you. 2 things, because I'm having a hard time reading this as, I need glasses anyway, readers. So there were a couple of things we were talking about with the FSA money rolling over and giving that back to the person. I forgot where we were with that. And then secondly, I think the IRS just deemed at least health savings account money and these types of monies can be used for direct primary care doctors. And I just wondered if that is the same thing with the FSA, if our consultant can answer that question.
We don't have any consultants on the phone, but as far as what we did this past month is we did allow, because the IRS allowed for a mid-year change to FSA, so employees could add more to their FSA or take dollars away. It was their choice. So we did do that for all of our employees. We did have people who made a lot of changes during that time period. But I think they did expand some things, so you can buy over-the-counter products. I don't remember.
Over-the-counter products can now be reimbursed without needing a doctor's prescription, as well as menstrual products. Expenses for that can be run through the flex plan as well. Don, you mentioned primary care
always
visits
been
could
there.
be covered. That always was, if you
Right.
use your
No,
flexible.
direct primary care. Direct primary care is where you pay your visit, $60 to $85 a month, and they don't send any claims to the plan, but they're your, like, it's the newer word for concierge. And before, it wasn't you couldn't use your FSA or HSA money for that, but I think they just got the law changed, and I'm just asking for clarification on that.
I have not seen that yet come from the consultant, so we'll see if they've got comment on that.
Typically, it's the same definition of what's an allowable expense, FSA, HSA, it's the same IRS guidance. So we'll get the consultant to confirm that, but it's just typically been the exact same list.
Okay. We'll take that back to Aon and make sure we get guidance on that.
So if we do have an alternate plan that's approved for next year, we feel it'd be appropriate to plan for an active enrollment and not have a passive opportunity at all. So everybody would need to take action in the plan. And similarly, for those who just for some reason don't seem to be able to get around to taking the action they need to take, we would want to set up a default plan so that they wouldn't end up without coverage. And we would suggest that that default plan would be the OAP plan, meaning the current plan, not the new alternate plan that we're proposing.
I agree.
Yes.
So Lisa, as you and I know all too well, every year, no matter how many reminders, there are folks that do not actively enroll. Is there some way we can set up like an alert, like a personalized alert within the last like 2 days if they don't enroll? I mean, I see you send like that, the final, like this is it, but rather, or in addition to that, like something more personalized right to them, either cell phone or, you know, email, something additionally. And I mean, it might not be you that has the ability to do that, but I don't know, Aon, somebody?
We do that. Go ahead, Lisa.
What we discovered, I think it was last year actually, is there is a feature in Easy Benefits that you can go by site and tell who has not yet enrolled. And so when we discovered that, we said, hey, I think next year maybe we will ask the site contacts to take a look at their list. We'll show them where in Easy Benefits that is, and if they wouldn't mind reaching out to those folks that still show a no by their name.
I think that'd be better, that'd be more personal, face-to-face. I think that's a good idea.
Generally, they answer their site benefit contact more than anybody else. So
Well-
that's why it works better that way.
Well, people don't check emails. That's a big problem.
Yeah.
All right. Is there anything else, Lisa?
That's it for me. Any questions? Thanks.
If not, we are to the open comment and suggestion portion. And I know, Anthony, at the beginning of the meeting, you mentioned that you had some things you'd like to bring up.
Yeah, I actually have several. So one of the things I had asked to be on the agenda, and I don't know if Brian is still on the line or not, but potentially our specialist co-pays are going to go up to, what is the new amount on that? 75, correct. And I had the question, well, put it this way. I went home immediately after the last meeting, and there was an explanation of benefits from a specialist visit that my wife had, and it only cost $58. So how are we going to charge people $75 copay if the whole services are less than $75? I mean, these people are just making donations to the plan. How do we ensure that doesn't happen? Because apparently not all specialist visits are going to cost $75 after discounts are negotiated and so on.
Maybe I need to go up here. Brian, are you still on the line?
Yeah, I am, but I'm having a hard time hearing something about a specialist visit.
Yeah, Anthony had a question about this. With the new plan year, based on a $75 copay in the OAP plan, Anthony indicated after we voted on that in our last meeting, he went home and looked at his EOB, and there was a specialist charge to the plan of $58. Is that correct, Anthony?
Mm-hmm.
Yes.
Right.
And the copay would be $75. How would that work, or how do we ensure that the plan is paying not more than what the total charge to the plan would be?
Yeah.
The
Is that
member-
correct? On that
the
email,
member
Mark,
is-
it's actually
The
has
member
the
is
same
paying
lesser of logic that your pharmacy plan has. So every provider has access to the Cigna web portal of what the actual client's benefit is. So it knows if you have a deductible, if they should charge that up front or pay is. If their actual reimbursement rate from Cigna is $58, I think it was in his example,
right,
and your copay $75, they're only going to charge you the lesser of. They would only charge you the $58, or they should only charge you the $58. If they charged you more once they got paid by Cigna, they would see that they would receive more than they should have, and they would refund the difference. Anthony, I can resend you that email if you like, or send it back to Mark. Can't recall who I forwarded it back to.
Yes, Jeff?
If they are able to see what the copay is, what they're going to get reimbursed, can the specialist just charge $75 to our employees? Is that what's going to happen?
That's not what Brian described. What Brian indicated was when the physician sees the reimbursement to them from the plan, if it's $58, the most they will charge would be $58.
So that they
Yeah,
can't
something
adjust
that
it?
low must have just been a follow-up visit, I'm thinking, because you saw just on the reports we went through, the typical specialist office visit costs about $182, I want to say roughly, I think it was. So I don't know why it would be that low, $58 for it. It could have just been a follow-up for, I don't know what it could have been, but typically they would be more than that. But if it's less than they would only charge what that reimbursement rate is from Cigna to the member.
Well, I think Anthony looked at his EOB and saw $58. And so...
Right, but your copay is not $75 right now, right?
No. The copay for a specialist is $50.
Right, so if it goes to
Anthony,
75,
not that I want to ask
they
you...
wouldn't pay 75, they would pay 58.
Not that I want to ask you any personal, but if it was, what were you charged for that copay?
What do you mean?
When you looked at the EOB, were you charged a $50 copay?
Yes.
Anthony was charged a $50 copay, and the charge to the plan was $58. That's what he's saying.
So it could have been a $108 reimbursement rate, because we usually share is from the contracted rate. If we paid out 58, it was 108 minus $50 member cost share leaves a balance of 58, and that's what we would have paid to the specialist.
I think the total was $58.
Don, I'd like to make a point on that, which is kind of interesting, because I asked it before when they were talking about the Cigna quality performance doctors, and I said, well, exactly what parameters are you using? And they said, well, that's internal and proprietary. And then I said, well, are those doctors paid less? Is that like part of it? And they were emphatically said no. Well, I actually spoke to a doctor today and said that they are proudly part of that, network. But in that, they're getting paid 80% of Medicare, which is not even what Medicaid pays. So I'm just letting you guys know this because it's nice if we save money, if we're truly saving money, but there's going to be a doctor shortage here shortly. Because to be paid 80% of Medicare for a commercial plan like the school district, we're not going to have a lot of doctors in Brevard. I'm just kind of letting you know. So I thought that was really interesting today because that's what I thought that it was on this quality thing. It ends up being a way for them to kind of pay them less, but they have a little star on their, on their website.
Don, I'm not aware of us paying a doctor less money to be in the care. Agree with that comment, but
No, you're
I'd like to know
paying them less. You're paying them less than Medicare rates, Brian. So,
And then we're paying every doctor less than Medicare rates, I guess, because
then
they don't
not-
get paid differently. They're not paid differently, Don.
Okay, well, then you're,
Participate if that.
because most, you know, on the commercial side, everything back to, you know, direct reference-based pricing is Medicare plus rates, because Medicare is kind of like the floor. But if we're going under the floor now, and then, you know, the providers are getting paid less, but the plans are going up, and the stocks are going up, I mean, we can kind of follow the money and see where things are going. So just-
I don't think we pay
break that
80% of
out.
Medicare. I personally don't think we pay 80% of Medicare, but I can't speak to whoever you spoke to, but I don't agree with that comment personally.
Well, here's what we could do, Brian. Can you, because we've got two different questions here, Anthony's and Don's statement. Is there any way you could give us an idea of, over the past year, how many physicians have left the plan compared to those who stayed on? In other words, do we have any shortages coming on in the Cigna plan in Brevard County? Because that might be a
Our
way to
total
test it.
our total turnover rate on physicians is less than 2% a year. Are you saying for Cigna Care designation only, Mark, that network?
I think altogether.
Yeah, altogether it's less than 2% turnover. 1.9, 2%, 2.1. It varies by quarter, but it's right around 2% or less.
But what's happening, this is Dawn, sorry, what's happening like right today, like I heard yesterday, 2 more doctors are moving to direct primary care only. So they're not going to be taking, you know, insurance. So if we're looking at historic values as to what's happening in history, we're not looking as to what is happening actually today. And in this COVID crisis, to be honest, we're going to see a mass exodus of healthcare professionals from the healthcare industry because of just how brutalized, you know, we are getting on the front lines of healthcare. So to look in the past may be interesting, but I'm just letting you know the reality of what is out here in the marketplace now.
Okay, thanks. Anthony.
I don't know if you were going to comment on what she was saying, and then I'll
No, I think I'm just,
okay.
Go ahead.
I actually found the explanation of benefits. So amount billed was $84. The discount was $25.66. Amount not covered, 0. Allowed amount $58.34. Copay $50. What your plan paid was $8.34. So clearly, if this was $75, we would have paid more. And I mean, I understand the reimbursement and all that, but that's another education piece, and that's going to be a pain in the neck for people if this happens frequently. But I mean, last meeting we had, I was told, no, that doesn't happen, and then it does happen.
Anthony, would you mind sharing that with me, and I'll investigate that?
Sure.
We'll look into that.
Yeah, I believe he sent that to you, Mark, and you forwarded it to me, and I got our provider relations who came back and confirmed they would only charge the $58, not the $75.
Brian,
the program set up with the physician.
Brian, I can assure you that yes, you will be getting that information. Any other questions, Anthony?
Just to clarify what Brian just said, is he saying at the point of service, the provider will only charge 58,
That's
or
what
that
he
they'll
said.
charge 75 and you would get reimbursed?
Brian, did you hear that?
I did not, I'm sorry.
What the question was is, at the point of service, is the patient charged $58 or are they charged $75, and that they get reimbursed the difference? Is that how I said? Is that correct?
You know, Mark, the provider's office should be looking at the Cigna portal based on what the actual client benefit is. And so they look at the portal and they look at what the member's responsibility is. And if he gets 58, they should then only charge the 58. Now, will there some billing people make a mistake and just look at their card and say, oh, you owe $75 and then have to be reimbursed after the fact? That may happen on occasion, but as a rule, they should be checking the Cigna web portal. At least they do for me when I go to the doctor, and they tell me exactly what I owe at that moment when I walk in there, because they know exactly what my benefit is and what the reimbursement rate is and what my deductible is.
All right, well, when I
should be checking the portal and charge accordingly.
When I get that EOB, I'd like a full description of what happened, and if that means we need to educate that doctor to look at the screens properly.
Well, Mark, I think that would process properly. The copay was $50. It was $50
That did.
minus the $50 copay, and we paid $8.
Okay.
There was nothing wrong with that EOB.
Right.
He's asking if it goes to 75, what happens?
Well,
What
that's
should
true.
happen is they would not
That's
pay
true.
75, they would pay 58.
Yeah.
Yeah, but from my experience, that all depends on who's doing the billing at that doctor's office, whoever the provider is, whoever's doing the billing, whether they charge you that amount or not. Because, frequently my wife, gets, reimbursements in the mail for a couple bucks here and there whenever we've been overcharged. So, but how do you know that you're due that money? Do we know all the details to get to that point where we could, ensure that we're getting that refund? I think is a concern. But I still don't, Mark, I understand you restated what Brian was stating a minute ago, but I don't think it addressed my question. What I'm concerned about is whenever the doctors or providers' offices realize that the floor for the BPS plan is $75, but they have situations where they're charging less, what are we going, what prevents them from raising their rates? What prevents them from changing their rates for those particular services? That's why I just want to make sure that we have some type of protection on
But
that.
don't they have to pay the agreed upon amount, right? They have to pay the agreed upon amount that's agreed upon with Cigna. It doesn't.
Yeah.
Cigna
And how
has-
often does that change?
Cigna has rates that they agree with the doctor, that based on this billing code, this is what they will reimburse.
No matter whose insurance, right? It doesn't matter
Correct.
whose insurance plan. That's their rates. Whether you're a BPS Cigna, person, or you're a Harris. Harris doesn't use Cigna, but I'm just if you're, right.
So
Everybody who has Cigna in our county they have the same agreed upon rates, I believe.
Yes, well,
we get
there are all
confirmation of
rates that Cigna has with each one of those physicians. So I'm not sure how often Cigna and those physicians renegotiate their contracts, but it would have to be something like that. They can't charge in excess of those agreed upon rates without getting that approved and agreed upon by Cigna.
And can we get confirmation if they don't have different rates for different plans?
Yeah,
But
Brian.
they do, but they would have different rates for different plans based upon networks. So that becomes a provider relations issue and a contract between the provider and the carrier, and that will be proprietary. They're not going to release that. But contracts between providers and insurance carriers are on an ongoing basis. All the time throughout the entire state and throughout the entire nation. So I think we're getting a little bit off base. Your concern was if we go to the $75 and we find out that the actual bill, the resulting bill, is less than my $70 copay, what have you, you should only be paying the lesser of. I believe that the way that will work itself out, and that's the importance of you reviewing your explanation of benefit that you got on that claim that you would receive on every visit, it would probably, the doctor's office is going to make you submit the copay. Once the EOB and claim gets electronically filed and satisfied, if there's an overpayment, a refund would then come back to the member. I had the exact same thing happen to me on the recent urgent care visit that I had shared with you. So they overcharged me, and I have to wait for that reimbursement. I'm pretty sure that that's the same way it would be working.
Yeah, I think that's the accounting question. My concern is, have we created a perverse incentive if there are actual examples where the actual cost of care is below what the payment is at the time of the care is rendered. So that's my only concern, is whether a perverse incentive was created there. So I know it's a little bit, I know there's a lot of proprietary issues there. Of course, all the shell games that appear to go on within healthcare makes it a concern. That's all.
Anthony, did you have other concerns?
Yeah, I have other ones and questions too. I just want to put it on the record that I am very concerned about the accuracy of the narrow network list or alternative network list when we go out for open enrollment. That list must be accurate. It cannot be wrong. People are going to be making huge decisions about healthcare based on the doctors on that list. It cannot be wrong. And yes, the assurances that it will be right have been given to me, but I'm not confident in that. Just this week, we've had a major issue with our flexible savings account where they switched vendors. About half the employees received no notification of the vendors being switched, and went to the doctors, went to pick up prescriptions. Their cards were rejected, and these cards, I think they are working today, from what I understand. But there was a period of a week where employees were unable to use their own money in their flexible savings account without notification. I didn't get any notification. Other people did not get any notification. So all of a sudden, we were just bombarded with angry people in difficult situations. So we cannot do that with the narrow network list. We cannot have another mistake like that. So I'm just really concerned about the accuracy of that list, and we need to know exactly who is responsible for getting the accurate list, because frankly, if it's inaccurate, I'm going to do everything I can to hold whoever that is accountable for it being inaccurate, because that will not be acceptable. This was not acceptable, what happened this week to our employees who could not access health care without their money. So I guess the question is, who is responsible for making sure that list is accurate?
It's a combination of my department as well as Cigna. We are working very closely with Cigna's provider relations to validate the listing of physicians. We've been in communication with them. In fact, we had a conference call this morning at 11 o'clock. So our goal is to have that list complete. We're going to verify everything on it is correct, and then it'll be shared with everybody on this committee at that time. It is a client-specific network, so that list are physicians that, of our choosing, so to speak. We're selecting physicians from Parish and Steward. What we are going to hopefully receive from them on a quarter or at least twice a year is an update of all of their physicians, so that's updated at all times. But we're still deciding how that will appear on the mycigna.com account, but we're working on that now. But by the time we're ready for open enrollment, that will be ready.
All right. I have a couple other questions, comments. What is the status of the audit on the well care centers?
I had a preliminary meeting. I wanted some more clarification. There will be a presentation to the superintendent tomorrow, and my goal would be to bring RSM McGladrey back during our next meeting to present their findings on the well care centers.
And Lisa, I'd ask you this question. The dependent audit starts July 13th. Do we know when that has to be completed by? Dependent
Oh, yes. Lisa, speak into the mic.
Oh, sorry.
Please start from the beginning, if you would.
The pre-announcement letter, which per the vendor on the timeline had us, the client, being responsible for sending it, was sent. There is far more communications yet to come. That was just an initial heads up. Mm-hmm. So in addition to an announcement letter that will be coming from the vendor, Impact Interactive, they also have a scheduled list of text and phone, mail blasts, email blasts, and further mailed communications as well. Was it August 24th?
August 24th. Yes.
The deadline.
Just to let you know, we also sent that to all site benefit contacts So the initial email went out to them to be distributed. We're sending out a mailing from our department, from benefits, to everybody in case they're not looking at their district web or their district email address. So we're mailing that home to them. They should get that next week. Is that, when was that supposed to go out?
They're going to work on it next week.
Okay.
We couldn't get to it this week. Also today, we worked with the communications department, and they just posted on the district website a little splash that says update to employee benefits, click here, and it takes you to the benefits page that talks about those two upcoming things, not just the dependent audit, but also the revised process for a reduced deductible in 2021 as well. That's ongoing actually right now.
I have two more things. So, if once we have this network in place, can a provider leave the network? How does that work? I don't know if somebody can answer that. Chris?
Yeah, a provider can leave the network, and we track that. Yes.
Okay. I just recently, I think we lost some doctors off our network, and I was wondering how that worked.
Mm-hmm.
Okay. And then the last thing I wanted to ask, and I mean, as we were exploring the alternative network, I think one of the barriers to folks making the switch to the alternative network is their primary care doctor. We were brainstorming, thinking about it. Would it be possible? Would it make sense? Would it ruin the whole plan? If we allowed folks whose primary care doctor currently is a Health First provider, if we let them have their primary care doctor be with Health First, kind of like grandfathered them in, or would that? You all follow what I'm saying?
I think what you're saying is if they're going to a Health First primary care physician, can they stay with that on the alternate network?
Well, I mean, I know as it stands now, they can't, but what I'm trying to ask is, would that drastically reduce the savings?
I think there is a savings difference because those doctors are paid a little bit more. But the biggest problem with that is when they're on a different network, they're going to be referring to their own system. So what you could have is a physician who would refer somebody to a Health First provider, and then everything would be out of network.
Right. I see Mike giving me the evil eye.
No, it wasn't evil. Well, I think, are you talking about continuity of care of somebody that's in the middle of a treatment path or somebody that's just looking to keep the existing provider they have?
Yeah. Just primary.
I think
care.
that kind of defeats the purpose of of going to that direct contract network.
We, right now, and I'll try and see if I can give another perspective, within our network, for instance, we have doctors who, are on the staffs of several hospitals. Some are on one. The understanding is that whatever happens in the office, that's our concern. But you also refer within network. So from the standpoint of, looking at diagnostics like freestanding imaging, lab, that kind of thing, surgery center, we would look to that to be within network. But we don't have a problem with the doctor saying, I'm also on the staff of Health First. We don't have a problem with that. Understanding when they're coming into the network that you're referring, though, for, key services within the network. Is that?
Yeah, is that, I don't know how all that works. Is it like a Health First doctor required to refer within the Health First network? Or is that just their go-to people?
That I'm not sure about. What I've been told is that typically, yes, the expectation is if you're employed through them, you're expected to refer within.
I guess the overall question is, if we think the narrow network is saving money, and we end up getting more to migrate to the narrow network because maybe they could keep their primary care doctor, would those savings outweigh if they just stayed on the OAP? That's what I'm trying to get at.
But didn't we have discussion that a lot of people's, like Chris was saying, people on multiple plans, a lot of the doctors in Health First may also be in the Steward network as well. So their primary might already still be on the narrow network. Might. Yeah.
I would say if they're just Health First physicians, they'll be coming off. But those who are on multiple plans will stay on this plan.
Is there a way for Aon to run those numbers? Like, I mean, because honestly, we're doing something that doesn't make great sense. We're saying we're saving money if people go to the narrow network, but we're actually generating more money if they stay on the OAP, and we raise their premium. So, you know, which is it that we want? Do we want people to stay on the narrow, the OAP, or do we want them to migrate? You know, so if in the long run we think migrating to the narrow network is the bigger cost, is going to do better for our plan, wouldn't we want more to migrate than to stay on the OAP?
Well, I think, if I remember correctly, during the presentations, they were assuming about a 50% migration. And there was a breaking point, I want to say it was like at 70%, where the cost isn't isn't beneficial anymore once we get above 70%. So that sweet spot of, what, 50, 60% is the goal, knowing very well most of the south end of the county is probably not going to migrate, especially the extreme south part of the county.
Well, I just would say, you know, I don't know if it was completely not beneficial, but it
There's like a
definitely
breaking
drastically
point, yeah.
reduces it. But I think the point is not, is it this or is it that? It's yes, both. Because what we're doing is we're creating an option so that our people who really probably, when they think about it real hard, won't really care if they have to change primary care physicians because they probably don't even see them. You know, I haven't seen my primary care physician in 4 years. So, I mean, not everybody's...
Hope they're not watching. Katie Campbell over here.
So, I've seen some other doctors, but it's not that, not her. So we're giving them an option where they can keep their rates low because they really have low usage. The people who have high usage, they're probably going to care more because they're seeing theirs more regularly. And so, but we're giving an option that is less expensive for the people who have lower usage, which, you know, that's what one of the things we talked about early on is and I know even before I got on, I heard regularly was we need another option. We need two choices. So I think the answer is yes, both.
Well, and I think at some level what you're saying is add the Health First primary cares. Where the true savings is in the inpatient utilization and outpatient. That's where we're going to save the big bucks, right? The high dollar events. The disparity between a Health First primary care visit and a parish is probably nominal under the direct contract plan.
Huge difference.
Well, but
No, stop.
okay, well,
Talk into the microphone. Chris,
You got to say that in the mic, Chris.
No, there are huge differences in cost. We are the third lowest cost hospital in the state, and that has been verified by the state of Florida. So no, I'm not going to be put into the same cost bucket as Health First. No way.
not on the hospital side, but on the primary care visit side.
Primary-
What are we talking in pure dollars, not percentages, but
Once again, it depends. If you've got doctors who are employed under Health First and it's under a Health First contract, the rates that they're going to get are going to be different than those that you have as a doctor who is independent and in private practice, even if they say they're on the Health First medical staff. So there are big differences.
The private practice doctors are primarily going to probably be in both networks already, correct? Somebody who's independent probably is trying to grab as many hospital networks as they can.
Yeah.
For volume.
I mean, well, and realistically, from when you look at the logistics of what can I cover, you know, if I have to be on call at multiple facilities, what is realistic?
If you recall what I said earlier, the physicians that are directly employed by Health First will not be on this plan. Those have been removed because they're the ones who are referring in-house into Health First and all of those.
Well, and the other part of it too is, if they're even permitted to be.
Well, that's
Because
true
if
as
you're
well.
the employer, you're telling them, what they're where they're going to be working and who they're working with.
Sorry, Anthony, I was trying to have your back.
I know, you were making my argument for me. That's, I mean, I just wanted to put it out there and kind of vet the idea a little bit. That's all. But I could see it could get convoluted if we do that.
I mean, the other thing you lose on that too is the premium delta between the two plan options too. And that's where I think that tipping point comes into play, that if too many people migrate over, the savings we better get from the narrower network better exceed the lost premiums that we're capturing. So, I mean, I think this is probably a very good entree into, let's see how this runs. Let's see if we truly net savings from it, and then, advance it from there.
We are going to have to reevaluate that, 3 and 6 months in, just to see how it's running.
Anything else, Anthony?
That's it.
Does anybody else have anything for the good of the group? Questions, comments, insults, anything? Insults.
Can I just say one thing? I know we've talked a lot about 2021, but I want us to start thinking about 2022.
Oh, for God's sakes, Mark.
We don't have to come up with ideas today. I'm not asking you to present ideas, but
Can we just have 1 month of not
but if there are things that you want us to look at and bring back and make presentations at a future SIAC, would you please send me that information as an email, and we'll schedule that and make sure that's part of the discussion. I know we've talked about HSA, HRAs, we've talked about different plan options, but I would really like the input from the group, especially if you have thoughts on how we can save the plan dollars, not just the plan, but employees. So if there is something that we can look at, I want to look at that, or we want to look at that to make sure we're saving the plan as well as employees as much money as possible. So if you could do that, I would really appreciate that.
Okay, if there is no other comments or questions, do we have a motion to adjourn?
Second.
All in favor? Have a nice day.
Thank you, folks.